everyone to our 8th webinar for the PIN-QUIN Maternal Equity webinar series. We are working to optimize racial equity across Massachusetts, and thank you all for all the work that you're all putting in to do that as well. You probably have already seen the common message that goes in the chat, which is as any of you log in, please put your name and organization into the chat for our roll call. We really appreciate it. And we'll take our usual agenda steps. We'll go over some data. Then we'll introduce our wonderful and esteemed speaker who will give us some information today on his utilization of data to bring about neonatal equity. And then we'll move into some conversation around QI. But we really want to make sure that everyone has time to ask and answer and receive answers to their questions, because this is really the crux of some of the things we want to accomplish with the PIN-QUIN Maternal Equity Bundle, which is how do we really use our data on our labor units to with every process and with every operation by race, ethnicity, or by your equity demographics or your demographics, so that we can look for inequities by subpopulations. So that's really key. If there's one thing we want to make sure people walk away with, it's that. All right, let's go to the next slide. And I want to say thank you to Anna and Kaylee for all of the work that's happening to make this happen, to make this webinar happen. So as usual, welcome. Please type your name and institution into the chat. We'll keep everybody muted until we open the floor for everyone to ask questions and to speak. And as usual, this is recorded. So you will be able to access the recording for this webinar on the PIN-QUIN website. Next slide. So we have a free Speak Up Ambassadors Implicit and Explicit Racial Bias Education coming up on May 25th. So then it's the next step in the series. You go from being a Speak Up champion after the 2-day workshop that we have folks do. It's either a full 1 day in person or 2 half days virtual. And then the next step is to become an ambassador. So for those of you who are interested in our ambassador training, we have an opportunity. Here's the QR code. You can also find the information on PQI's website. I'd love to say that we have trained now over 500 champions in the state of Massachusetts. So thank you to everyone who's raised awareness and gotten the word out. And for those of you who've taken the education and training and passed it on and passed it forward. Thank you. And go to the next slide. Here's a testimonial for us. The Speak Up Ambassadors workshop was amazing. I enjoyed the intimate small group number of people. I felt that we all had the opportunity to share our experiences and opinions. I was able to gain a better understanding of how to prepare a QI project. That's really key. All right, we'll go to the next slide. Thank you to Annie Garcia for her testimonial. So as usual today, again, we'll go over some data, then we'll bring in a conversation from Dr. Fraiman on neonatal equity. And then if we have time, we'll go into our QI teaching. There are times when our QI teaching, we skip over that because we want to make sure we lean into the conversation of the guests coming. But when we do get there, if there's time, I'm going to be excited to talk about ways that the work that we're doing in quality lead toward improvements. And so I want to give some more background information on that. And we'll use Dr. Bingham, and Deborah Bingham is the founder and CEO of the Institute for Perinatal Quality Improvement. She has grouped some of these expert recommendations into a nice mnemonic that many can remember, the ABCDEs. And so we'll show everyone what that means. All right, we'll go to the next slide. And for any new folks who've just joined, please put your name and institution into the chat. Thank you always and again to our PIN-QUIN Maternal Equity Bundle work group. So many faces, so many wonderful folks to bring their opinion and expertise to this work to shape it and make sure that it's successful for everyone. So if there's anyone that also wants to join the bundle, the Equity Bundle work group, please don't hesitate to reach out to myself or to me or to Kaylee Vitek at PINQuinAdmin at pinquinma.org. Here are our participating hospitals of the 22, and we'll go to the next slide. And just a reminder that as you submit data as a team, it's required that you have a memorandum of understanding. Sorry, I did an overnight flight, so I'm going to hit a few words wrong with the BLC, but then also that you have your structure and process measures for all AIM bundles implemented by the 10th of that month. All right, we'll go to the next slide. Oh, okay. Did you know that we accommodate retroactive data submissions? So you can go back as far back to September 2022 when the bundle kicked off to put in your data. BLC can send you the survey links to catch up. So if you have questions, please don't hesitate to email Kaylee. All right, go to the next slide. And here we go with a data review for our structure measures. So I wanted to highlight a couple of structure measures. And one is the progress towards our diversity towards diversity of our formal equity team. So as you can see, we have a number of folks who have equity teams that they're working on. We do, and so I'm going to have you just zoom your eyes in on the top set of under community member November through April, that actually there is a navy blue there, or deeper blue. There is a team that has a community member as part of their formal equity team, and that's really important. We're going to hear more about that with Dr. Fraiman too, and around how they form their equity team at BIDMC. But I wanted to say that we're making progress. And so we have a speaker coming next month who's going to talk about their work in Colorado to do the same thing in terms of supporting community members joining your formal equity teams in your institutions, and why that's really important. You've heard that from a number of speakers, but we'll hear more about it again today. All right, we'll go to the next slide. And so for collecting demographic data, we're doing really well. You see a lot of blue moving across. And so we're improving all the time in terms of those who are fully in place collecting race, ethnicity, and language. And then when you go to the next slide, you can see that self-report is there where we want it to be. We want this to be self-reported. That is the gold standard that we'd like to aspire to. And I say that, I wanted to say out loud for those of you who feel like that's a given. There are places where people have put projects in place to have this assigned when someone does not self-report because they want to complete their data sets. And so that's just something to keep in mind, that can happen, and understanding why it's important to work with communities so that self-report, the trust is high enough there for self-report to be successful. All right, next slide. And stratifying data. So again, we'll hear more about the work that's happening at BIDMC in the neonatal unit. The goal is that we're working to stratify data in everything that we do by your demographics, so that you can not only say anymore that we're achieving a quality standard for your population, because the populations differ in terms of their cultural background, language, race, ethnicity. We want to achieve quality metrics for all populations and not the population. All right, we'll go to the next slide, and we're moving in that direction. So with the process measures, we haven't really spent much time on process measures, and we will over the next 3 months. The one that we want to highlight today, we'll go to the next slide, is that of the first, which is training. It's really important to know that we've trained over 500 champions, and within the last training for those who have had implicit bias, racism, and racial disparities training within the last 2 years, we see that number continuing to go up. That light blue bar is nursing, with the darker blue bar being physicians. That said, we have higher numbers of nurses being trained, but we can see where those trends are going in the right direction and increasing, and so it's really important. All right, we're going to talk more about other process measures moving forward. We'll go to the next slide. As we go into the summer months, and just wanted to say out loud that the two measures that we're thinking about, of course, are the hypertension and hemorrhage. And we see a lot that with hypertension, actually, that many folks that are being treated in a timely manner, that we actually are not seeing too much of a disparity. So I think that's going to be a nice thing to see as we move forward. But as we go into the summer months and we talk about these process measures and we talk about what we're working on, we wanted to ask you guys, we know that the summer months are times when we see less attendance. And so this poll here that you may see is, which equity webinars are you likely to attend this summer, July, August, or both? And we're asking because we plan to host both months, but if we noticed that there was one particular month that people plan to not be available, then we would make a change there, because this, of course, is for you guys as the audience. All right, so we have 25 of 40. So if we can try to grab everybody that can to answer the poll, it'd be really helpful. And so we can get 5 more people to give us an answer, and then we'll move to the next question. And if you've just gotten on the webinar, please put your name and your institution into the chat for roll call. Awesome. We'll give it 10 more seconds, and then we'll close out the poll. We have about 80% participation, but for those of you who really want to answer the question, which equity webinar are you likely to attend this summer, July, August, or both? It looks like the majority of folks are also saying both. All right. We can end this poll, I think. Nice. You guys can see, so yeah, both tended to be the focus here. Okay. So without further ado, I'd love to introduce our speaker today, who is Dr. Yarden Fraiman. He is a neonatologist at BIDMC. He completed his residency training and fellowship at Boston Children's Boston Medical Center, and then was a fellow at the Harvard-wide Pediatric Health Services Research within the Health Services Research Fellowship. And what I really love, actually, as I was looking more into Yarden early on, and when Dr. Jopp introduced, the great work he was doing is Yarden. I love what it says on your Twitter, where it says using research to inform systems level change to create neonatal equity. And I think that is so appropriate and so wonderfully said. That's that nugget of information that fits. So he's going to talk to us about the journey that BIDMC is on to pursue neonatal health equity. And you're going to hear a little bit more about forming your equity teams, how to diversify those teams, how to keep the momentum moving forward, and then stratifying your data by race, ethnicity. So let me not take any more time and turn it over to you, Dr. Fraiman. Sorry.
No problem. Thank you. I apologize for being in scrubs and my doctor uniform of Patagonia vest. I am currently on service, so I appreciate. Can I start the share? Okay, awesome. All right, are you guys seeing the? Perfect, thank you for the thumbs up. So I won't be able to see the chat actually while I'm talking. And so I really would just say this is supposed to be a conversation. Please, by all means, feel free to just unmute and jump in. So thank you again for the invitation to speak today. I'm super excited to talk with all of you as you guys are going on this journey. And I'm going to be talking about the journey we had at the BI, and specifically to know that it is a journey. We're still on it. We're not done. And this is a work in progress. So before I begin, I'd like to start with my land acknowledgement that while speaking from Boston, Massachusetts, I acknowledge the original inhabitants of this land, including the tribes of the Wampanoag, Nipmuc, and the Massachusetts nations, and recognize that it is upon their sacred land where I live, work, and play. I acknowledge them as the original stewards of this land, and I recognize that their absence and the ever-present inequities we experience, and that we'll really be discussing today, are the result of violence, forced removal, disenfranchisement, and ethnocide. Furthermore, as the heirs to that legacy, I recognize our important collective role in reckoning with the past and promoting and securing justice for the future. I have no disclosures that are financial, but I do have a personal disclosure that I want to make right now, and acknowledge that my own identity as white, Latino, first-generation American, as the child of immigrants, as the grandchild of refugees, as a gay, cisgendered Jewish man, acknowledge that those are disclosures that I have to make, and that I have to acknowledge that that informs why I do this work, the lens with which I view this work, and also my own biases. And I also want to acknowledge that I am more than what I seem, right? I think most of us are. And I think that part of this work is actually acknowledging the complexity of our identities that we all contain within us multitudes, and that those are important for us to see and recognize in each other. So a couple of norms before I start. I think these conversations can be tough. I know you guys have been engaging in them super actively. You guys are all choosing to be here, which is wonderful. But nonetheless, we often misspeak. We often make ourselves and others uncomfortable. And so I think in order for there to be good collaboration and growth, these are the ABCs, or the norms that I set out when I speak. The first is assume best intentions, both of each other and I hope of me as well, so that when we misspeak, when we have a hard time finding the right words, we know people are coming from a good place and trying their best. B is for that this is a brave space. I often hear people say safe space. I think people feel like if it's a safe space, they can say whatever they want, whereas a brave space is a place where we can grow from. And so I want people to be brave in this space. And, part of that is leaning into what Kamara Jones says, right? The edge of my discomfort is my growing edge. So I think we should all lean into that. And then finally, that this is a conversation and not a lecture. Really do feel free to unmute and call out. This is supposed to really be hopefully useful for everyone who's doing this work. So today, these are kind of the things I'm going to be talking about. We're going to kind of discuss a little bit of the BI's journey to health equity and explore in that kind of why racial and ethnic health inequities exist and our model for thinking about that, the importance of partnership that Audra had already started to talk about, discuss the projects that we're working on right now, and then take a bit of a deeper dive into our equity-focused quality improvement work that I'm hoping will be useful as you see someone else doing this work. And I think the important thing is that that I hope to convey is that there isn't like one right way to do this work, right? This is just the way we do it. And so I think part of that is figuring out what's the best way for you to do it in your institution. And this is one model, and hopefully seeing one model can help. Before we began this work, I think it's important to establish kind of what's the model you're using for understanding racial and ethnic health inequities. And so for us, that meant starting from a place of recognizing that race is a social construct. I think people say this a lot. I think in this audience and with the number of PQI Speak Up trainees that are here, I think this is a well understood fact. But the reality is when you're working at the hospital level, like not everyone is going to understand this. And so really feeling firm on this understanding of race allows you then to kind of talk about it in a way that's succinct for the rest of the hospital when you are coming up against potential barriers. And so I like this definition from Nancy Krieger over at the Chan School in Boston. And she says race is a social, not biologic category, referring to social groups, often sharing cultural heritage and ancestry that are forged by oppressive systems of race relations, justified by ideology in which one group benefits from dominating other groups. And she goes on to say that race leads to the enforced marginalization of people from positions of power, coupled with the assumption that white, economically secure, I would argue cisgendered het men are allegedly the norm, right? And so this is really all about kind of how we use race as a way to organize society by consolidating power and creating systems of exclusion. And so, what I like to tell people is when they say, but how can race be a social construct if when I'm riding the bus into work in the morning, I see people that look different than me. When I look at the Zoom boxes, I see people that look different than me. We're obviously different. And the point is, right, well, what it means that race is a social construct is that where we draw the lines to say you're part of one group and this person is part of a different group, that's the social construct. And you can look at this through history and through politics, through culture, and you can see that, right, people who were once part of one group became part of another group, right? And that allowed them or afforded them more access or less access to power. The second kind of important piece for us is that racial and ethnic health inequities are the result of racism. And for us, when we talk about racism, we're specifically talking not about the racism that I feel like I learned in school, which was like racism is about bad people doing bad things to other people, but racism as a system that's organized, into these four categories, which have been very nicely kind of described by Kamara Jones and David Wellman at the macro and the micro level. So we're going to take like a couple of minutes just to dive deep into this, because I think that if you can understand that inequities are the result of racism, then you can begin to do that work of walking back when you're seeing inequities and actually thinking about where that's coming from. So starting in the bottom left-hand corner, so institutional racism. So institutional racism is the racism that's embedded in laws and policies and practices, right? This book here by Richard Rothstein, The Color of Law, is a really great book that kind of shows the way in which the legal system in the United States, even after kind of the end of Jim Crow and desegregation, was still used to enforce kind of residential segregation in America. And so, I think that oftentimes people feel like institutional racism is, Jim Crow South, right? But I like to remember that for us, institutional racism is also the racism that's embedded in the laws and in the policies. And so what are the hospital policies? What are the institution-specific systems in place that potentially uphold racism within your system? So for example, a hospital that might say, we don't do skin to skin on the evening shift because we're short-staffed and we need more people, right? Well, if over 50% of the US population are shift workers and can only come in the evening, and who in our country is disproportionately shift workers, mainly people who are non-white, then really that policy, that institutional policy, is upholding institutional racism. And so you can actually look for policies in your hospital. And often institutional racism is hiding in plain sight. Then we have structural racism, which is different slightly than institutional racism. While institutional racism is kind of more policy driven, structural racism is the racism that's embedded in the systems in which we live. In some ways, what I like to say, it's the water we're all swimming in, right? And so structural racism is things like growing up, I didn't see people on TV who didn't look like me. It's the fact that in my own medical training, I never saw a medical illustration of anyone or any body that wasn't a white body. And so like, how does this actually manifest into health inequities? Well, if I never learned how to diagnose or recognize, let's say, jaundice in someone who wasn't white, then despite my best efforts, I may still have a delayed time to diagnosis for jaundice. And that's not because I'm a bad person or I'm doing a bad job or intentionally trying to, put a baby who's not white at a higher risk of, neonatal bilirubin encephalopathy or kernicterus. It's because the system is actually designed for me to fail those patients. And that's structural racism. So again, like that's the racism that, again, just like institutional racism, it lives in plain sight. We're all swimming in it, right? But then you begin to see it more and more. Just up from that, we have interpersonal racism. This is the racism that I think most of us learned about. This is like bad people doing bad things. This is about like implicit and explicit bias. This is a picture of Christian Cooper. He was the birder in Central Park in 2020, I believe, who had the police called on him when he asked a white woman to leash her dog in Central Park. I have here the book White Fragility by Robin DiAngelo. This is, I don't think any of the books that are out there on race are perfect, and surely this one is also not perfect, but I think that this book actually does do a good job for white people, recognizing some of the ways in which they continue, despite their best efforts, to continue to kind of commit, for lack of a better word, interpersonal racism. This is where your like implicit bias training, explicit bias training, upstander training, your speak up training becomes super important, right? But it's only one piece. And then the final one is internalized racism. And internalized racism is the racism that people from minoritized groups begin to believe about their own abilities. And then they often, as was showed by Claude Steele, a sociologist at Stanford, begin to actually kind of underperform as a result of that. So this one I think is the most complex and difficult to understand. And the examples that I give are from my own lived experience. So as a gay man, right, there are many stereotypes about gay men. One of them is that we're not athletic or we're not manly enough. And so there are times when I'm in certain spaces, like, at the park when there's a basketball game going up, that I think to myself, like, I can't play that. I can't play with those people. Like I'm not part of that group. I'm not manly enough to play basketball with them, right? And that's my internalized homophobia. It's the way that my 16-year-old niece says, like, she hates math because girls are bad at math, because she has now received that message from society and begins to believe that about herself. So it's important, like, when we see like racism as this giant system, that we can begin to then, again, when we're thinking about health inequities that we see in our units, in our hospitals, think like, what's the driver? And so you can think about it also in terms of the social ecological levels of influence, right? Where an individual's health this theory was developed by Brofenbrunner, individuals' health is influenced by these kind of different hierarchical realms that affect us. The individual health, what's the family context, what's the community and neighborhood context, what are the policies and laws under which those people live, and all of these exert pressure to either support or put down someone's health. And in some ways, these align nicely to these levels of racism: internalized racism, interpersonal racism, structural racism, and institutional racism. And so what we need to remember is that it's racism and not race that shapes the lives we live by creating these lived contexts, which contain the codified differential distribution of power and access and opportunity, right? So thinking about Nancy Krieger's kind of definition of race, it's really operationalized through racism. And so in some ways, really, right, it's racism that creates race, as Dorothy Roberts says, and not the other way around. I think there's a lot of really great stuff written on this topic. I think this piece by Rhea Boyd in Health Affairs Forefront is phenomenal, and really helps to drive home the point, the way in which health practitioners and researchers really need to name racism in their work and think about racism when they are thinking about health equity. The third model for our racial and ethnic inequities work is that racism is addressable, changeable, and modifiable. And we use the public health critical race praxis, which is essentially this praxis that states that it's grounded in the understanding of race as a social construct, and racism is embedded in society, but it really thinks about research as a pathway from exploring drivers of inequities to creating interventions around inequities. And so you'll notice that I always say inequity and not disparity. And the reason is because for me, healthcare disparities are population level differences in health, whereas inequities are population level differences in health that are avoidable, unnecessary, and unjust. And when we begin to think about those differences as inequities instead of disparities, we really can begin to move to orient our work toward health justice. And so I've kind of moved away from this idea that I do health equity research to saying I do justice-oriented health equity research, which is specifically research that focuses on modifiable drivers of health inequity, really racism, right? And that's what all of you guys are doing, right? In these equity bundles, thinking about data, thinking about interventions, you're really thinking about creating health justice. So before I move on to the next part, which is kind of diving into the work we did at the BI, I do want to take a minute and just open it up and see if there are questions or comments. I don't know if there's anything in the chat. Let me check quickly. Awesome. Thank you for putting those articles in there. Did someone say something? Sorry.
I just said nothing in the chat. Everybody's listening with rapt attention.
Okay. All right. So I will go on. So I think, now that we kind of have this foundation of understanding how this work started, I do want to talk a little bit about our BI journey. So this slide has a lot of text on it, so I will walk us through it. But the journey of health equity at the Department of Neonatology predates me, right? So my department chair is Dwayne Pursley, who's a thought leader in health equity work, but there wasn't really health equity, quality improvement, targeted anti-racism interventions happening in the department. So I completed my fellowship and joined the BI in 2021. And because of my background, because of my interest, kind of immediately recognized that there wasn't a health equity committee. And importantly, and I think this is the first point, that it wasn't there, that committee, which didn't exist, also needed to be embedded within the NICU leadership committee structure, right? How often do equity committees or DEI committees or diversity councils exist within institutions, but they exist kind of in their own area, right? So there's no accountability for the work, right? There's no one monitoring your progress. There's no reporting structure. If you meet your goals, great. If you don't meet your goals, great. There's no consequences, right? So that was super important. The next step was to identify a partner, right? I knew that I could not do this work alone. And actually, I knew that, as probably everyone on this call already knows, that the movers and shakers in our units are our nurses, right? Like, they are the life source of our units. Like, they are at the patient bedside all the time. If you want to make a change, if you want to create equity, if you want to create quality, that has to happen with nursing partnership. So Connie Clausen is one of our unit-based educators and was very passionate about this work. And so we partnered up and we established the Neonatal Health Equity and Justice Committee, which we call Just Babies. And that is a subcommittee of our NICU Leadership Committee. Now, it's important that it's part of the NICU Leadership Committee, because actually our compensation is linked and our bonuses are linked to achieving goals. So there's incentive now, right? People want to do this work. People want to get involved. So this took about like 3 months, right? And then we developed a charter, and our top priorities were to integrate a racial equity curriculum for our new hires, to complete a racial justice assessment of the NICU, to institute universal social determinants of health screening for the NICU, and then finally to disaggregate our quality improvement data by race and ethnicity. So then the next step was to build a committee. And I think, Audra talked about this and the importance of partnership. So I wanted to show you all of the people that are on our committee. So it's chaired by myself and Connie Clausen. We have physicians on our team. So we have nursing leadership on the team. We have nurse practitioners on our team. We have clinical nurses on our team. We have respiratory on our team. We have one of our unit coordinators and patient care associates on our team, Dina. We have social work involved on our team. We have our administrative staff on our team. And then we also have family partners. So Molly Wiley is one of our NICU family partners. She's actually embedded into the department here. And then she recruited 4 additional families to join our committee. And so this is important for 2 reasons. One, by being integrated into the NLC or NICU Leadership Committee, we're integrated into that structure. So there's accountability, right? But the second piece of it is that we also include family members. So we are accountable not only to our organizations, but to our families. And so that goes back to what I think a lot of people have heard, right? Like, nothing about us without us, right? So the next part was building partnerships, not just within the NICU, not only with our families, but also across our institutions, because this is work that you don't have to do alone. So I partnered with our OBGYN DIA committee. I think I saw Alicia on here, who's part of that committee. I think Rose Molina and Chloe Zara, who are also involved in PinQuin, are also members. I know there's a lot of other BI representation. So that was one. Then we are thinking about creating a dyadic equity dashboard, right? So how do we create research partnerships and technological advancements across departments? I'm a member of the HMS Equity Working Group. So I'm seeing what other people are doing, right? We established the Neonatal Justice Collaborative, which is a grassroots organization, which I encourage everyone to look up, which also provides support. And again, including families at every stage of this work. So I think that, I heard Rhea Boyd talk yesterday, and she talked about how you have to be good to yourself in this work. And that is so important. This work is exhausting, and it's really, really hard. And there's a lot of burnout in our field. And so I think creating a community around this work, whether it's through your organization, cross-departmentally, at your institution, or through PinQuin, knowing that there's that system of support can be incredibly useful in helping each other. So we're going to dive into the 4 projects that we focused on in the NICU Health Equity and Justice Committee. Sorry, I keep looking over. I'm just keeping an eye on my very big clock. So the first step was instituting universal social determinants of health screening. So, I think this is important because even though the inequitable distribution of the social determinants of health is a result of structural and institutional racism that leads to that inequitable distribution, We still knew, right, that this was something people were super motivated about. It was evidence-based, and it made a huge impact for families. So we adapted a screening tool that was initially put out at BMC, developed by Arvin Garg there at BMC, who's now at UMass. This is the Thrive or We Care. We modified it for our environment. We had it vetted by families of our NICU Family Advisory Council. And so we give this to every family. And then it comes with it with a resource guide. This project was led by one of our social workers and our nurse practitioners, Roseanne Buck, who's wonderful, and Dory Zipperstein. And so I think, one of the main pushbacks we had on this was like, well, if we ask, we have to fix every problem, right? How often have we heard like, it's actually harder to ask. And if we ask, then we have to do something and we don't have the resources. But actually asking in itself is important, right? We may not be able to fix every problem, but if we have awareness, we can help. We can support, we can be present. Also, if you measure how much social determinant of health need there is in your unit, you may actually be able to advocate to your hospital on getting more resources, getting more social workers, getting more access, right? Because what gets measured is what gets done. This social determinants of health screening tool was developed with an accompanying resource sheet, which is posted in our unit. It's given to every family, whether they ask for it or not. It's posted in the bathrooms and it's posted on our NICU app, right? So even if families don't want to share, they still can access the resources that that are available. Our next piece was to develop anti-bias, anti-racism upstander training. So both myself and Connie Clausen are Speak Up ambassadors. And so we used that knowledge and our experience, and we developed a 1 hour-long curriculum for all of our new hires. And so it was just integrated right into orientation. There was no question, like if you wanted to take it, opt in or opt out. It was just, this is what is part of our orientation now. This is our value. These are the values we stand by. And so this is required now. And it's been great. We've seen an incredible increase. We've been tracking our results of both increases in knowledge and changes in behavior. As part of our curriculum, every single person is given 10 minutes to complete the implicit association test or the kind of implicit bias test that's developed out of Harvard. So if they haven't done it before, they get to do it right there and face their own biases. That's the first step of making your implicit bias explicit. We use the Speak Up mnemonic to kind of help them to have tools. So this is great. And by measuring the positive impact that we had, then in this coming year, we've actually been able to integrate this into our NRP training. So every person in our unit needs to be NRP trained. They already get 4 hours blocked off. So we partnered with our NRP instructors and said, hey, could we take an hour of that time and do this? They said yes. So now every person who recertifies NRP, which is everyone in our unit, within 2 years, we're going to get everyone, right? We're going to get all the new hires when they onboard, and then within 2 years. And we got CEUs and CMEs. So then like there's even more of an incentive, right? So I think that's part of this work, right? It's like you should not be doing this work in isolation. You should be embedding this work, right, into what already exists, leverage what already is there. The next thing we did was our racial justice assessment of the NICU. So this is, there are a lot of formal racial justice assessments of non-clinical environments that exist in the business world, but they don't exist for healthcare. And so we wanted to formally evaluate the space to see like, what is the structural racism that is in the NICU, right? So we did a literature review of the existing tools that were out there. We pulled the questions that were most relevant. We went through iterative discussions and created this tool we call the Healthcare RJAT, or Healthcare Racial Justice Assessment Tool. And the nice thing is that each measure is in itself an action item. So for example, there's a measure that says like, does your unit have images on the wall that represent all families? And the answers are easy: red, yellow, green. Like red, no; yellow, we're in process; green, it's done. Like if you're a red, then you can just say like the intervention is embedded in the question, right? So by doing this kind of equity focused kind of quality improvement PDSA cycles with this tool, we can just slowly make our environment more racially just. And the goal here was to say, like, so many of our interventions are people-based, right? They're all based at that individual level. It's hard to make institutional and structural change, right? In equity. We do it all the time for quality. But for equity, our default is to look at people. And so this pulled us away from people and to say, what is in our environment that we can address? And then finally, our equity-focused quality improvement work. And so this is where I'm going to spend a little bit of time just diving in, just because I know that this is a main focus for many of you here. And I think there's the potential for us to have rich discussion about all these things, but around equity-focused quality improvement in particular. So by diving in, I think it's important first to kind of acknowledge what is equity-focused quality improvement. And this piece by Vicki Reichman and senior author Michelle Marie Pena she's now at Emory, is a great article that helps to kind of focus us on why quality improvement can actually worsen inequity when we don't use an equity-focused approach. And so taking a moment to just talk about that, because I think that's really hard, right? We often think like if we make things better, they will look better for everyone, right? Like if the mean goes up, everybody moves up together. But the reality is that when you're only measuring like the aggregate data, an improvement might actually do this to your distribution, where your mean is actually the same, and it might make things spread out more, but moved a little bit. But what I worry about is actually this, where you see that people at the bottom don't move very much, but people at the top suddenly move a lot. And so if you're only looking at that mean, if you're only looking at your data in aggregate, you actually may be making things worse by making things better for the people who already have, right? And not improving things for people who you are trying to focus on. And we see this all the time, right? Like, for example, like we know that technological advancements are inequitably distributed, right? So when you think about like access to my chart, increasing access to medical records, who has computers and connectivity and internet at home to access their medical records easily? The people who already have those things. So in some ways, the people who are already having access get more access, and the people who never had access are left behind, even though that mean changes. And so when you look at your quality improvement, is it getting better for everyone? Is it getting better for everybody, but better for some more than for others? Or might it look like this? And so the thing to remember is what gets measured is what gets done. If you are not measuring it, you're never going to be able to address it. And as my chair, Dwayne, likes to tell me, garbage in equals garbage out. If you have bad data going in, you are not going to have good answers coming out. And so the first piece of that is really defining an infant's race and ethnicity for us, thinking critically about what is the best way to do that. And so what we did is we said, okay, well, we know that there's race and ethnicity in the electronic medical record. I'm totally over time. I'm so sorry. Should I keep going or rushing? Okay, all right. To look at our EMR data. So the first question was like, what is the state of our EMR record? So we did a 3-month audit. What we knew is that the birth certificate is the gold standard for babies' race and ethnicity because it's filled out by birthing people about their babies. And it includes in it both parents, if they choose to, race and ethnicity. So we have a wonderful member of our staff here who went through 3 months of every baby born at the BI and looked at their EMR listed race and ethnicity and their birth certificate race and ethnicity. She looked at 598 babies. She had taken out the outborn babies because birth certificates are filled out at the birthing hospital. And as BI is a quaternary referral center, we get a lot of outborn babies. And what did we find? Of the 588 babies that we looked at, we had 18% said unable to obtain, 6.5% said other, and 2.9% said patient declined to answer. So we had over 25% missing, right, for different reasons. And so what she did is she went through and she validated it. And what we found was that after she validated it, our missingness went down to 3.9%. So that means that race and ethnicity was available in the birth certificate for these babies, but it wasn't in our EMR. And importantly, she found that if there was a race or ethnicity in the chart, only 4 babies were misclassified, which is also really important, right? Because then you can say like, okay, we don't need to actually go through every single baby. The, error is actually low. It's missingness that is the problem. So then we said, okay, let's map out this process. How does race and ethnicity get from someone in their room having their baby to the birth certificate registry and the EMR? So the birth person registers when they go to the hospital. And at that point, or at a previous encounter with the electronic medical record, their race or ethnicity is put in. When the birthing person has a baby, the birthing person's race or ethnicity autofills for the baby. So if the birthing person's race or ethnicity is wrong, the baby's race or ethnicity is wrong. And I just want to pause here and say, this concept of like pulling a birthing person's race or ethnicity as a baby's race or ethnicity is totally buying into the biologic fallacy of race, right? Like race is not an inherited thing. And we need to acknowledge that like this method of data collection is in itself on some level upholding racism, but it is the best thing we have at this moment. Then the birth registry employees meet the family. They leave the paperwork. It's either filled out by the family with or without assistance. Then the paperwork is filled into the Vital system, and then it gets zipped off to Vitals. And then the documentation is scanned and kept as a kind of scanned record, but no paper record is left. It's not in the medical chart. It just kind of disappears. And so what we needed to figure out was like, where can we intercept this process to get the birth certificate data into our EMR data so that we can do the quality improvement work? So what we have started doing is our wonderful colleague, Eileen Malala, she actually will intercept the process. So when there are babies who have missing race or ethnicity, she logs in, she looks at what it is, and she fills it in. So she does that work manually. Now, I will say there's a project coming down the pipeline. I think Fifi's on here, where we are working toward figuring out how hospitals can get back actually this data, because this is an inefficient system, right? Like we have families filling out self-reported race ethnicity data. We should be able to access that so we can do equity-focused quality improvement. But part of that is still ongoing. Updates to come. And then the question is like, what metrics do you track? And so what I would encourage you to think about is like, think about again, like disparity versus inequity versus justice. What are the things, what are the drivers of the inequities you're interested in? Also, choose something you're already looking at, right? Like all of our hospitals and all of our departments already have quality measures. You do not need to reinvent the wheel. And actually, I think that there's a huge advantage into stratifying data that you're already looking at. Why? Because we chose, for example, skin to skin for very small babies, right? So if we find an inequity there, you know who owns that inequity? It's not me. It's actually the people who do the skin to skin quality improvement work. And so in that way, again, you're embedding quality, you're embedding equity into everyone's work, and it's not staying siloed within your department. And then think about your context, right? Like don't choose a metric that's different. Don't choose my metric if it doesn't work for you, right? If you're a level 2 special care nursery, skin to skin for VLBW babies may not be the best metric for you, right? But maybe like breastfeeding at discharge is, if you're a baby first hospital, right? So I'm going to just show you quickly, because I think there's value in knowing that these graphs don't look pretty and they don't look they're not embedded in our EMR. We do not have Epic, for example. So these are small, but the point is they came out really small. I apologize. So we have our different race and ethnicity categories at the bottom. Blue is 2021, orange is 2022, and gray is 2023. And this category right here is the NA, other, undecided, unreported, essentially missing race ethnicity. And so first of all, like if you're going to do quality improvement to increase the collection of the data, track it, right? If you can track it, then you can also figure out when there's inconsistencies in your data. And then this one is our time to hold by race. Again, I'm so sorry it came out so small. But essentially, this is, in green is babies that are not held. Red is babies that are held late, and blue is babies that are held early. And what you can see in 2023, which is this category right here, that between Black and white babies, there's our inequity. You can see we've only had on this set of data one baby who's Asian or identifies as Asian. That baby was held late, so there's an inequity there too. And part of it is also saying, like, what's my N, right? Like, how many babies do I have? We know that for most of our data, we have to look at it quarterly because we can't look at stratified data monthly. But the point is, if you're already looking at this data, if you're already doing it in your Excel sheets or in your QI software, like, you can just do it. Just stratify it. Just get the data, make sure it's right. So I'm going to leave us there. I totally went over. I'm so sorry. I'm going to unshare and leave it open for questions, and hopefully we'll have some time for discussion. Thank you again. There's my email. If we run out of time, I'm always happy to be emailed, and my Twitter is there, though I'm not really on Twitter as much as I once was. All right.
That was terrific. Thank you so much, Dr. Fraiman. Everyone's clapping in the background. There were 2 questions in the chat, so I wanted to make sure we called those out. Barb Stabile at Brigham Women's asked the question, could the curriculum for upstander training be shared?
Oh, I would have to talk to Connie. I don't see why not. Our curriculum itself has a lot of personal stories. We felt like there was a huge advantage for us taking the time to say, here are the ways that we faced our own racism, our own implicit bias. And so sorry, who was the question? What was the person's name?
Barbara Stabile.
Okay, Barbara, you're at the Brigham. You are welcome to come to the BI anytime and see it. I feel like that is probably the best way. We don't have it filmed, and we don't have it on anything like New Innovations, because we realize, like, people need to be in the room, like, people need to be together. But yes, Barbara, just email me. We're always happy to bring people in and have them see it. Absolutely.
Thank you. Oh, that's terrific. Yeah. Also, we think of Speak Up as an upstander training because it gives people the mnemonic on ways they can speak up. But there's just a challenge, and sometimes having different trainings too allows for different personalities and different styles to really be able to connect to everyone. There was also, you made a comment around doing in the Just Babies, around doing a racial justice assessment. At our institution at UCSD, we did the same thing. We used the white coats for Black Lives report cards. So I put that in the chat as well. I didn't hear, which one did you guys use?
Yeah, we actually created our own. We didn't feel like there
Okay.
was one that was specifically good for our context. And so what we did is we had a multidisciplinary working group, and we actually did a literature search and started to pull we created what we called a Franken survey early on, and then ultimately created one survey that had these questions that fell into multiple domains. And the goal was really to create a survey tool that could be used iteratively to show improvement and with real actionable items on it.
Well, I would love to have you share that one too, if that's a shareable as well. We're asking for everything you talked about. There was one additional question in the chat around I'm losing it for some reason. I know it was you, Sarah. Oh, were you looking at the mother's race ethnicity or the babies? And I believe when you were talking, you might have said that it was the mom's race ethnicity. So I just want to make sure. Okay, great. Thanks, Sarah.
Yeah. Usually, I'll just comment on this quickly. Like, most research is really based on birthing person race ethnicity, which, like I mentioned, is inaccurate at right? Like, our identities are complex, right? What does that mean for babies that have multiracial families? What does it mean for families that use a gestational carrier? What does it mean for families that use an egg, like a donor egg? What does it mean when we say race is a social construct, but we're just taking the birthing person's race, right? Like, so I think you have to acknowledge all the weaknesses in that, right? And yet it's like the best tool we have, unfortunately.
Yeah.
Add one comment. It seems to also rely on us doing a good job collecting the birthing person's race and ethnicity, which I'm not clear at my institution that we are doing.
Yeah, and that's exactly why we did that EMR audit and comparing it to the birth certificate. And so at the BI, what we found was when it's asked, it's usually correct, but it's not consistently asked, right? And so that's why we've developed the system with Eileen and are working with DPH to think about ways that we can kind of utilize the data we're already collecting to do equity-focused work.
That's really great, Yarden. There's one more question in the chat too that I wanted to say something about it just before we say it out loud. I think Katie asked a really great question. We're gonna hear more about it too at our next webinar, but I'll ask you and let you comment. What I really love about this, and something you said earlier when Barb said she'd love a field trip, it's nice. This is what PinQuin's about, the collaboration, dropping the silos, dropping the walls, being able to talk across institutions so that we can really get things done. This is not the space where we want to compete as health systems and institutions. We want to be able to do a great job for everybody. So I really appreciate, you being open and willing to share. And then Katie asked a really great question, and something that many of us are thinking about, because you guys have done a really great job of this. And I think pediatrics sort of has a culture that has been longer standing than obstetrics in terms of doing this kind of engagement with family, mostly because your patient really is more than just the one person. It's the parents and the caregivers as well. But Katie asked, aside from Molly Wiley, how did you get families to join your group? And were they compensated for their time? That's a big question. And how did you capture diverse representation? And I'm going to throw one more in there on top of Katie's two sections. And that is, how did you also logistically or legally make sure that they can participate in a way that they can hear what's happening with BIDMC issues without being a member of the faculty or staff of BIDMC?
Yeah. All right. There's multiple parts of that question. So in addition to Molly Wiley, our unit, our family support system keeps a track of families. Like we keep track of our NICU families. We have contact information for them and families that say they want to stay involved. And so when we were developing who we were going to reach out to, we asked Molly to include on the list of families she pulled, families that had wide diversity of representation in terms of race, ethnicity. We also wanted families who pulled from outside of like the Boston catchment area, because we have people who are at Winchester and Plymouth and Beverly. And so we wanted kind of a wide swath. And then also in terms of the demographics, right? Not every baby in the NICU is a preemie baby. And so we wanted to make sure we had families on our team who, had babies who had babies with congenital malformations, or who had HIE and who had other issues in our NICU. So that was the first piece. We don't compensate. There is no mechanism within our work to compensate. It is a big issue for us. Families that come in person do get parking reimbursement, so it is a nominal amount of help. It is a big problem. In the work that I do outside of this, that's grant funded, I always do include grant funds for family members. So I think if your equity work is funded by grants, you can write family partners into your grants. And then there are other ways that I think that we can create inclusion, right? Like who can show up to a meeting at noon on Zoom? Not, not everyone, right? So we've committed to at least have one meeting in the evenings to allow for people to bring their kids if they want to bring them in. So you can have more flexibility that allows for potential more inclusion. Audra, to your question about like the legality, I don't know the answer. I think it's just like our departmental culture wants families to be involved in this work. Every subcommittee of the NICU Leadership Committee is like by mandate has to have a family member. And so it's just like part of our ethos. And so I don't think there's the barrier there that we've encountered from a departmental standpoint. Don't tell the CEO of the hospital.
Well, I just one more time, thank you. Lots of accolades in the chat. Thank you so much for everything you've said. It really was a nice way for people to hear a summary, also a wrap up of comments that have been made here and there over the course of the last 6 months. I think you put everything so nicely. And Kaylee and I are both looking forward to hearing what you were going to say about the graphics and the charts, and it flowed so nicely. It was wonderful to hear just how you're right. If we don't think about all populations, if we look at the population, those charts and the dotted lines can get lost to everybody's view. And so I think it's really important. So thank you so much. We know it's 1 minute over the hour, and we will see everyone on third Tuesday of June, on June 20th, where we will have Colorado's PQC come and speak to us about family engagement. And so looking forward to seeing you all then. Thank you.
Thank you again for having me. Feel free to reach out with any questions.